welcome to the second annual University of California, San Francisco Multiethnic Health Equity Research Center Research Symposium. I am Jane G, an associate professor at UCSF and a co-director of the Multiethnic Health Equity Research Center, also known as MERC. MERC is housed within the Division of General Internal Medicine in the UCSF School of Medicine and unites investigators across multiple disciplines, departments, and schools. We conduct community and practice-based clinical and outcomes research on health services, specific medical conditions, and prevention that addresses racial and ethnic disparities in health and healthcare in the pursuit of health equity. MERC is committed to promoting the development of minority investigators and supports training and mentoring of students, residents, fellows, and junior faculty. MERC has built a network of relationships with diverse community-based organizations and strives to incorporate the community perspective in training and research. To learn more about MERC, please visit our website, merc.ucsf.edu. Our agenda for today's symposium will include a keynote address by Dr. Kirsten Bibbins-Domingo, followed by brief research talks from each of the three MERC Emerging Health Equity Scholar Awardees. A question and answer session will then follow after all the talks. During the symposium, please use the Q&A box to submit questions at any time. We would like to thank the UCSF Division of General Internal Medicine for their collaboration and sponsorship for today's event. Next, I'll pass on to Dr. Maria Garcia, a co-director of MERC, to introduce our keynote speaker.
Welcome, everyone. It is my pleasure to introduce Dr. Kirsten Bibbins-Domingo as our keynote speaker today. Dr. Bibbins-Domingo is the 17th editor-in-chief of the Journal for the American Medical Association. She is the Lee Goldman, MD, Professor of Medicine and Professor of Epidemiology and Biostatistics at the University of California in San Francisco. She previously served as the chair of the Department of Epidemiology and Biostatistics and as the inaugural Vice Dean for Population Health and Health Equity at Zuckerberg San Francisco General Hospital. At UCSF School of Medicine, sorry. She co-founded the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General that focuses on actionable research to improve health equity and reduce health disparities. Welcome, Dr. Bibbins-Domingo. And we will let her cue up her slides and begin.
Thank you so much. It's such a thrill to be here today, and I appreciate that very kind introduction. Mostly, I'm pleased to be here because I also started out as a MERC scholar, and it was such an important community for me early on in my career, and then also throughout. So it's a particular thrill for me to be here today. So I want to. I've titled my talk "Making Stones," and this is a theme that emerged for me over many years of doing research and being a faculty member at UCSF. When those of us who are interested in issues of health equity, in issues of improving health and thinking about how we do our research in order to accomplish those goals, are oftentimes faced with a bit of a dilemma. And that dilemma is really that we want to make change if the issues are related to particularly issues of disparities or advancing health equity. Those changes are urgent. They're often rooted in issues of injustice and unfairness. And if we're trying to use research tools in order to build the scholarship in that area, we're often left at this tension that on the one hand, we want to urgently make change because of something we care deeply about. On the other, the things that we hold dear in science and research are much more objective, dispassionate, careful, considered. And the question is, how do we reconcile those tensions where we're researchers, but we are really doing this work because we want to ultimately see a change and an improvement in health for particular populations of interest. And so as I evolved over my career I was really informed by this piece of work from Kelly Brownell that was published in The Lancet in 2015. And the framework they were thinking about related to obesity researchers. And the question for them was, obesity is such a big problem that we want to see change. But the question is, how does any one of us who is doing the science related to this bring about that change? And this is a very simple schematic, but is one that was really important for me. Ultimately, if you're trying to bring about change, you really want to understand the people who are, and the agents who are really proximal, the change agents, those people who actually are in decision-making authority, actually are on the ground, the people who are closest to the type of change that you seek. You have to identify them and really understand the questions that are important for them, because those can help us as researchers to develop more strategic questions. So not just the questions that are of interest to us or convenient to us because they're variables that are in a data set, but rather the strategic questions that relate to the things that the change agents need to know the answer to in order to bring about change. We conduct our scholarship in the way all of you do, the way I have done, my colleagues have done, with the same rigorous criteria that we think about scholarship in general. We want to communicate here. Communications here is not just doing the best work in the best journal, but rather thinking about those areas of communication beyond just a journal publication, whether it's presenting to community organizations, presenting to the legislature, thinking about other means for lay communication, thinking about communications with other specialty groups who might be related to the work that you're doing. And then ultimately communicating in such a way that change agents have the information so that they can build about the next set of things that they want to do. And so this cycle then repeats itself. While I'm going to give you some examples that relate specifically to policy-related research, policy-informed research, one can apply this framework, I think, to a variety of ways of thinking about the research and scholarship that one does. And I'd urge you to think about how this framework works for you. Now, this is the framework, as I said, published in Lancet. I do like the sort of pithy way of thinking about this that my colleague Laura Schmidt said to me one day, and I don't know if this is her quote directly or if she's taken it from someone else, but I'm going to attribute her. She said, you know, scientists make the stones and then they give the stones to the advocates to throw. And the reason I like this is because I think it recognizes that you need both stone makers and stone throwers. It recognizes that the stone throwers might be more proximal to bringing about change, but there is a need to actually make the really strong stones. It separates the two, but recognizes that both are important for bringing about the change that one needs. Now, I hope there are some stone throwers who are on the screen today. But not all of you are going to be stone throwers. Some of you are working with stone throwers. This also works to think about this way. Scientists make the stones and they give them to builders to build. One thinks about this for ways in which we might use science to build about a new practice guideline or to think about change that might happen in a clinical practice where you're building on the work of others to actually put a set of things together that will ultimately hopefully bring about the type of change that you want to see. So the question is, can you use the framework of thinking more strategically about the stones we make to make us better when we hand them off to builders or the advocates, or as we are building and advocating on our own? And I think that's what I wanted to explore. So I have today two examples from my work that have happened over a long time of doing this work. I've been at UCSF for a while. I usually give a longer talk on this. I hope I can get through these two examples, and then hopefully we'll have a little bit of time for questions as well. So the first of these relate to salt. Now, I'm going to tell you this, that I'm eating my lunch and I'm eating a wonderful salty lunch here that I had just before this meal. So I love salt as much as anybody. The reality is in the US, we eat too much salt. This looks at the distributions of sodium consumption in the US. Most of us are eating way too much salt, like 98% of us are eating way too much salt. The challenge of reducing salt in the diet is that salt is already added to the foods that most of us eat. Most of us eat too much processed food, processed or prepared food, where the salt is already added to the foods. Reducing salt is important because it relates to high blood pressure, other types of cardiovascular disease, processes related to elevations in blood pressure. And it's the type of thing that individuals can't really they can make informed decisions on their own, but there's so much salt in what we eat, and it disproportionately impacts communities where the choices around them of what they're able to have available as food are more restricted and more likely to oftentimes to have higher concentrations of sodium. This just shows you that nearly 80% of what we eat is in processed and prepared food. Very little is related to the salt that we put on our food at the dinner table in the salt shakers. So most of us are eating too much. Most of it is already added to the foods that we eat. So we were interested in this question: could small reductions in dietary sodium have an impact on population cardiovascular health? This is the research question I came to after listening to my colleague now at Stanford, Glenn Chertow, a nephrologist, say, everything that we do in terms of reducing blood pressure would be better if there was if everyone consumed slightly less salt. And he said one of the biggest barriers to this is that the FDA has sodium in a category called generally regarded as safe, meaning the FDA thinks there's no amount of sodium that is ever bad for you. And if the FDA could change that particular rule, it would allow many who work in thinking about the composition of the diet and think about regulating foods and labeling foods and other types of things, it would help them to do this. But because the FDA hasn't changed this rule, many of us are left with, sort of constrained in these areas. And he said the FDA is debating this later this year, and a lot of people are really interested in how to get this changed. So we decided, knowing that this was a timely topic and an important topic and one that was related to a policy change, to do some modeling around this. So this is work we did with this cardiovascular disease policy model. And what we were projecting was not the question that others had asked, what does a low sodium diet do? But rather, what would it take if every piece of processed food, prepared food, had slightly less salt in it? The types of things that would happen if you actually had a policy change that incentivized or restricted food manufacturers from the types of things that were added to food. And what we showed was that a small reduction in dietary sodium across the entire US diet would result in fairly substantial improvements in cardiovascular health. These improvements would be larger for younger people. They would be larger in African American communities, both because of the relative balance of hypertension and the consumption patterns. And this was, when you look at these numbers overall in the population, these are large numbers that everyone benefits, and some groups proportionately more. And those were important because those are groups that we were concerned about in terms of premature cardiovascular disease. We also decided to compare this intervention to something that we knew the public health community had already thought about and was interested in. So in this case, saying if we could reduce dietary sodium in the US by 3 grams per day, that would result in the same number of lives saved as if we could reduce smoking by half. Now, I see Dr. Ling on the phone, and so I want to make sure that I emphasize that smoking is terrible for you, and we have to get everyone to stop smoking. And if you're an individual and you're counseling a patient, you want to tell them, and they're smoking, that's the most important thing they could do. But across the population, the reality is those who smoke it's dangerous to themselves. It's dangerous to others who might inhale smoke passively. But all of us are eating pretty much too much salt. And so this is a population intervention that if the FDA changed their way of approaching it, could result in small benefits for many people, and that on average, those benefits across the population equated to the number by reducing the tobacco consumption by half in the US. So this got the attention. This work, combined with others, got the attention of the FDA. And the FDA, soon after a series of articles were published, actually announced their plans to limit salt allowed in processed foods. This work helped give the numbers to the Department of Public Health in New York City that was very active on this issue and partnering with food companies to actually engage in voluntary reductions of sodium in their food products. And actually over time, what you see is that the amount of sodium in many processed foods actually went down over time, not because anybody noticed it or cared about it, but because a lot of people were activated on the same topic and put both carrots and sticks in place related to this. And so I start this because there was nothing brilliant or magic about the work that we did. I think the work that we did had an impact because we understood the regulatory environment and the timing, and we understood how to ask a question in a way that got the attention at the right time. I want to give you a second example, and this relates to the pandemic. And during the pandemic, one of the things that our group did was to think about how we understood excess deaths in California during the pandemic. How many more people died during each month of the pandemic compared to that same month in prior years. That allowed us to think about both the direct and the indirect effects of the pandemic on mortality. And we did this for California data. So we asked, how has excess mortality varied by population subgroup, and can this inform future interventions in the pandemic? Now, there was a lot of discussion during the pandemic of essential workers and that they faced a higher risk. An unfortunate fact is that we collect very little data on occupation in healthcare settings, and it's very hard to get at health risks by occupation. But what we realize is that death certificate data actually does have occupation on it. So when someone dies in California, their family member says what their occupation was. And we had the advice from people who study occupation. They said, you know, that data is probably really messy, but there is no data out there. And if you could use that data to give some numbers about the occupational risk associated during the months of the pandemic, that would actually be a contribution. And so we worked to take that data from the death certificates. We had a lot of advice for people who do study occupation to know how to do this well, recognizing the limitations of the data. Yehang Chen, who was the PhD specialist who worked and led this work in the Department of Epi, called me one night and he said, you know, I'm going to post this work on excess mortality by occupation on a preprint server tomorrow morning. He says, we have to do this now because in California, they're debating how they're going to roll out vaccines and who's going to get COVID vaccines in what order. And he says, this work is really important. So we knew the work was important. He convinced me. We put it up on the preprint server, and then it got picked up by social media, and it got a lot of play on social media. What we found was that if you worked in facilities, if you worked in food and agriculture, if you worked in manufacturing, if you worked in transportation and logistics, that you had a markedly increase in your risk of dying during the pandemic compared to those same sectors in the prior years. And the highest here was really food and agriculture. So this was giving people numbers that we sort of knew intuitively. It was giving people numbers at a time when those numbers were important for other policy decisions. It did get picked up by others. This was from Science News and Science Magazine, really showing per occupation who had the highest risk of death. In this case, cooks ended up at the top of our list here. It's this and other work that I think when you saw how vaccines were rolled out in California, put food and agriculture workers at the top of that list, at the same place as other sort of individual set of comorbidities that put one at higher risk, in this case, because of the higher exposure risk in these populations. This plus other work was a part of the bigger discussions about how did farm workers, how did meatpacking workers, how did other types of workers in these sectors, the disproportionate burden that they experienced during the pandemic. And then when the Supreme Court debated what are the responsibilities for employers during times of public health crises, this included several of the citations from our group on this work again. Again, is this science? What was important about this science? It was really about knowing the right question at the right time for that others who were making change needed to have the answer to. That's what I think was the most important about this work having impact. So my advice to all of you as you're embarking on your careers or whatever stage you are is to really pay attention to the world around you and what people want to know about the areas in which you work. I'd urge you to think about understanding the change agents in whatever field you work. There's always somebody there who is making the guidelines, who is developing the practice protocols, who's thinking about the policies that relate. Use that understanding to think more strategically about the questions you ask. We always have to conduct rigorous, high-quality scholarship, but we want to communicate not just in journals like JAMA, but communicate sort of broadly and to a whole range of individuals, populations that need to understand this work that requires different modes of communication, and ideally have this work reach those people who are going to bring about change. And I think this can make for a very satisfying way of approaching the scholarship that you're engaged in. So my advice here, this is pay attention to what's going on around you and why things that you think are important to do research on, what it would take to actually bring about change. Be prepared. Whenever somebody like me gives a keynote, it always looks like it was easy to get here, and it never is. This is work of teams. It's work of teams that are prepared. It's work of teams that are thinking all the time. This is not something that is just like comes along easily, and you're all doing the hard work now to get in those positions. So be prepared. And then I'd also urge, be creative and take some risks. Some of this goes, again, knowing that something is time sensitive. It is something that might be a little bit more risky. And I think these fields ultimately have the greatest rewards when we're creative and we take some risks. So whether you're a stone maker, a builder, or a stone thrower, or any number of these, I hope that you heard something that was of importance in the talk. I think these careers are really wonderful, and thinking about how we use our science to bring about some of the change that we'd like to see in the world is the opportunity that all of us have. So with that, I'm happy to have questions if we haven't gone too long.
I think we're leaving the questions for the end. Is that the case, sir? I think so.
Yes, that's the plan. Thank you.
Thank you. Okay. We would really like to thank Dr. Kirsten Bibbins-Domingo for presenting, agreeing to participate. It's always a pleasure to listen to her insightful presentation, and also thank her for her contributions to research and health equity. With that, we're moving to our first awardee. And it's really a pleasure and an honor for me to present Dr. Elissa Hamlat. Dr. Hamlat is a clinical psychologist and researcher. She is one of our Center of Aging and Diverse Community scientists, and she's currently an instructor in the Department of Psychiatry and Behavioral Sciences at UCSF. Her research focuses on the transition to puberty as a developmental period of risk for physical and mental health problems. She's interested in racial and ethnic differences in early adversity and the timing of puberty and how these factors may contribute to health disparities, particularly between Blacks and white women. So, without further ado, Dr. Hamlat, please go ahead.
Thank you, Celia. That was a wonderful introduction. Yes, my name is Elissa Hamlat, and I am very excited today to share some of my work on how early life adversity can result in accelerated aging throughout the lifespan. And as Celia said, I'm especially interested in the pubertal transition as a time of risk, but also as an opportunity for intervention. So when I'm speaking about early adversity, in my framework, I'm primarily talking about the ACE construct, or adverse childhood experiences. These are usually broadly categorized as abuse or neglect before the age of 18. And as you can see here, they have impacts throughout the lifespan, including earlier onsets of disease and disability, and ultimately premature mortality. And there's a lot we don't know about the mechanisms at work here. Sorry. One of the mechanisms that I'm interested in exploring, it's been mostly a theoretical idea, and I take my framework from life history theory, specifically the psychosocial acceleration hypothesis by Bruce Ellis. And this is an evolutionary psychology idea, which holds that if you're maturing in an early life environment that is risky or adverse, the body may, through cues, tend to accelerate your pubertal development. And we don't know how this happens. We think it has something to do with the recalibration of the HPA axis and affecting the stress response. And the HPA axis also affects the timing of puberty. But basically, it's a way to hurry up and reproduce before you are put out of the gene pool. So it's actually an adaptive strategy over the lifespan. And I'm particularly interested in how the effects of early life adversity might affect puberty differently in Black and white girls. I'm especially interested because traditionally the puberty literature has been really homogenous and has been focused on white girls, specifically middle-class white girls. And also because Black girls tend to mature earlier than white girls. And this is a previous study I did in which I found early life abuse led to earlier pubertal development by age 10 for both Black and white girls. And I found a larger effect, though, for the Black girls. So this made me wonder, how was this adversity not only affecting puberty, but actually biological aging that might go on through the lifespan? And one of the primary ways that I measure biological aging is through the use of epigenetic clocks. The developer of the first clock, Steve Horvath, described it as counting rings on a tree or rust on your DNA. And through a series of machine learning algorithms, it's basically using patterns of methylation in your genome that have been trained to predict age or mortality. And so you can get a sense of how old your body is relative to your chronological age. And the best clocks we have right now, the newest generation, they do a good job of predicting time to cancer, time to heart disease, time to frailty. So I became interested in looking at the effects of early abuse on epigenetic aging, how that might speed up the biological aging, but also what about the role of puberty. And so age at menarche is your age at your first menstruation. That's one way of looking at pubertal timing. This is another study where I found significant effects of both abuse and first menstruation on epigenetic aging. So I decided to look at this on a larger scale that included the effect of race. So I'm really lucky to be part of a group of researchers that looks and works with the growth and health study from NHLBI that was actually started in the late 80s, where a large cohort of Black and white girls were recruited at age around 9, 10. And we have one cohort here locally in the Richmond area. They received the gold standard pubertal assessment every year for 10 years. And recently, I and some other researchers followed up on this cohort in early midlife. So about age 39, 40, we went back and we asked them retrospectively about their early life abuse. I specifically focus on that as the kind of most potent form of adversity. And we also looked at their biological aging using epigenetic clocks, but also using telomere length and CRP to gauge inflammation. And it was about almost 400 women, pretty evenly divided by race. And so this was my hypothesized model in which I'm looking at the effect of early abuse on the aging, but it goes through, there's an indirect effect that is going through age at menarche. So abuse is going to, earlier puberty is going to accelerated aging. I looked at the effect of race on each time point, abuse, puberty, aging. And I did something a little different in that I created a latent variable to kind of capture the variance across these different ways of measuring biological aging. And I also did that for my abuse variable because I had different methods of looking at different kinds of abuse. And what I was looking for, actually, I found my main hypothesis, which is that there was an indirect effect of abuse on the aging through menarche. But I also found another path of risk here where, and I'm going to break this down a little more, where the Black girls had, separate from the early abuse, had an earlier age at first period, and that also led to biological aging that was accelerated. Just a note here that I looked at the effect of childhood income as kind of a way of controlling for financial adversity. It's not perfect, but I did that at each time point. And I also, for the biological aging, accounted for their current income as well as their current age. So again, the women who had more abuse in early life were earlier at first period and then had an older biological age according to this variable. And then the Black girls separately on their also had earlier period, earlier age at first period, and also were accelerated compared to the white women. So what are my conclusions here? I mean, broadly, early abuse, but also the experience of being a Black girl growing up in the United States, which could be characterized as an adverse environment, might actually be speeding up your physiology, and that might be beginning in childhood. And this might contribute to some of the disparities we see between Black and women, even when we control for SES and other factors. And a lot of the problem is, and I'm trying to do this next, is we don't do a very good job of measuring adversity that might be more specific to the experience of being a Black girl. This may seem sort of negative in that early life factors have such a far-reaching effect, but I also am excited about the idea that if we're not able to limit ACEs, which I definitely think should be a broad area of concern. I'm very inspired by the first Surgeon General of California, who has implemented some ACE screening in I think many areas of medicine, including primary care. But I'm also really, really passionate about intervention during the pubertal transition, because I think that that's such a plastic, interesting time to impact girls and boys and protect against this accelerated aging. This might be one way we measure the effect of interventions, and ultimately lifespan. Hopefully they're having healthier outcomes throughout their life. I just wanted to thank the Center for Aging in Diverse Communities, which has just been a fantastic support for me and has given me so many good ideas, especially Tor Nealons, who was my statistics mentor. Yeah, and thanks the NIH and also the Center for Health and Community that I'm lucky to be a part of. So that is what I have, and I'm very happy to hear the rest of the presentations.
Great, thank you so much, Dr. Hamlat. Such an interesting presentation and really important questions. Really looking forward to the discussion we'll have later. It's now, I'm Dr. Pam Ling, and it's now my honor to introduce the next speaker, who is Dr. Nhung Nguyen, and we'll let her start sharing her slides as we get started. Dr. Nguyen is an assistant professor in the Division of General Internal Medicine. She's a behavioral epidemiologist who has expertise in tobacco control research, and her research program focuses on leveraging mobile health technology to reduce substance use among priority populations, including people with mental health or substance use disorders and sexual and gender minority young adults. So currently her projects that she's the PI on are focused on developing personalized interventions for tobacco cessation utilizing smartphone apps. And in the bigger picture, her work aims to advance health equity by increasing access to evidence-based substance use treatment for disadvantaged and underserved populations by developing tailored interventions that meet their needs. I am delighted that Nhung is a member of our division as an assistant professor, and am consistently so impressed by her maturity, her creativity, and her modeling servant leadership, both as a researcher and as a parent, and as she becomes a mentor herself. So delighted to introduce you, Nhung, and looking forward to your presentation.
Thank you so much, Pam. And thank you so much for everyone for attending the symposium today. It's my pleasure to be here today and present and share with you my work. Before start, I want to shout out to my mentors, Dr. Pam Ling, and all other mentor collaborators who support me throughout my career, and also the funder who support for my research. So I want to give you a little bit background about me and what motivated me to do the health equity research. So as a people who was born and grew up in Vietnam, my core value is diversity, equity, and inclusion. And it's really guided me as a researcher. So I said my missions on my stone is that I want to advance health equity for everyone through the mobile health research. And it's a guide for my professional and career going throughout everyday basic work. I want to do the impactful work to solve the real world problem by creating the innovative and inclusive solution for everyone. So this background really guide and become the foundation for my research program that's advanced health equity. Throughout my career, I keep asking me the question about what's the most important public health issue I should solve. For example, I want to learn about why people use tobacco and how we can help them to quit tobacco use, how we can reduce health disparity related to tobacco use and other substance use. And I'm trying to understand among the different types of at-risk population who at risk and have the higher risk of tobacco use and other substance use. In my research, I combine the method from both epidemiology and mobile health because I believe that it can provide a complementary picture of both population level and individual level, help me to understand the problem more nuanced, and ultimately to find the answer for my question, like to have the solution for the problem I try to solve, such as my research indicated the determinant of health behaviors of tobacco use. And also now I'm trying to develop the intervention to help people quit using tobacco. And now I want to give you an example of my previous research that I use mobile health method to understand the use of tobacco and other substances among sexual minority young adults. So you may ask why we need to care about sexual minority young adults. Because they have the highest rates of smoking compared with other age and sexual identity group. As you can see in this graph, based on the national data survey, we see that clearly we saw the cigarette smoking disparity by the sexual identity group, that sexual minority have a higher rate of cigarette smoking compared with those heterosexual. However, we also see the intersectional disparity by age group, is that young adults between 18 and 25 years old even have a higher rate of smoking compared with people who's 26 or older. So this high rate of smoking may result to the health disparity among this population, which may be increase the risk for lung cancers, cardiovascular disease, or mental health disorder. And I have the two questions I asking in my mind. Like the first question, whether the real-time predictor of smoking differ between the sexual minority and heterosexual or not. And my second question is that because I also observed that sexual minority people have a higher prevalence use of cannabis and alcohol, so whether they are using tobacco with these substances or not. So to understand these nuance issues, I use the smartphone to collect the data to understand the substance use behavior. And the name of this method you may heard about is called ecological momentary assessment. So what it means, we repeatedly assess substance use at the random time or the fixed time during the day via smartphone. And by using the snapshot of the behavior, we can provide the richer picture of the behavior, more granular data, and then we can understand this behavior in the deeper level. And this type of data collection can also increase the data validity and also reduce recall bias. Using the data collected from this method, I can answer my research question. And here's the result for the first question. We published the paper for other drug and alcohol dependence and found that we found the same predictor for both sexual identity, such as nicotine craving, availability of the cigarette product, and when people at the outside location, they're more likely to smoke cigarette. Interestingly, we found some unique predictors for sexual minority. That's being at bar or being around with other smokers increase their likelihood of smoking cigarette. So this finding has some implication for intervention that we may provide the intervention, smoking cessation intervention at bar to target sexual minority. And I also presented this result at the UCSF Health Disparity a few years ago. Regarding to my second question, whether young adult, sexual minority young adult are using tobacco with other substances, the answer is yes. And in another paper, we found that sexual minority more likely to use cigarette and cannabis together, and also more likely to use all three substances, cigarette, cannabis, and alcohol together, compared with heterosexual. Again, this finding provides another insight for the tailored intervention for the smoking cessation, is that we may not only address cigarette alone, but we may need to take into account cannabis and alcohol use to try to help people quit cigarette smoking. So in summary, this pilot study used mobile health research to collect the data to reveal the real-time predictor of smoking among sexual minorities, and also to indicate the multiple substance use patterns in this group, and ultimately to provide indication for future interventions to target this predictor and target multiple substance use to reduce smoking disparity and health disparity in sexual minority young adult. So this study provides use an example of my previous research that I try to understand determinant and impact of substance use. Currently, I'm developing smartphone-based intervention for tobacco cessation for young adults. And in the short term, in the future, I want to expand this work to other populations who have higher risk of tobacco use to reduce health disparity related to tobacco. And in the longer term, I want to expand not only focus on tobacco cessations, but also to develop to the other behavioral intervention among more diverse population, ultimately to achieve my research mission to advance health equity. And I strongly believe that using smartphone can help us to advance health equity because the smartphone ownership is very high among Hispanic, Black population, low-income population, high school or less or rural population, which we can use smartphone as the modality for deliver our evidence-based treatment to reduce health disparity in these populations. So in conclusions, my research mission is advance health equity for everyone through the smartphone application. Thank you so much for your listening. I'm looking forward to other talk.
Thank you, Dr. Nguyen, for that really interesting data that you've shared with us, and we'll look forward to discussing this in a little bit. Now I would like to introduce our third scholar, Dr. Charles Windon. He is an assistant professor of neurology at the UCSF Memory and Aging Center. His research explores the use of novel imaging and blood-based biomarkers for the detection and diagnosis of Alzheimer's disease and related dementias in populations that have been historically excluded from research. He also seeks to understand the intersection between social determinants of health, like where we live, where we play, where we work, and racial and ethnic identity. In addition to the Alzheimer's disease biomarkers, to this research, he participates in the clinical care and management of those with cognitive decline and leads outreach efforts to the African-American community in the San Francisco Bay Area. Today, he's going to share with us the results of a pilot project called the Ethnocultural Differences in Fluid Markers of Alzheimer's Disease. So I will turn it over to Charles to share his findings with you.
Thank you so much for the warm welcome, Grace. Tremendously appreciative of all your attention this afternoon, tremendously appreciative of the organizers of this event and MERC as well as my mentorship team and the individuals who made this research possible. So I really seek a world where we no longer have inequities in Alzheimer's disease and related dementias. And so the background to my pilot is that there have been ethnocultural inequities in the incidence and prevalence of Alzheimer's disease, and related dementias that have been reported across the literature. We know, for example, based on the literature, African-American and Latinx individuals have a 1.5 to 2 times greater risk of Alzheimer's disease dementia. However, the driving force of these inequities is incompletely clear, despite the years of research that have been developed for the purposes of answering these questions. We know that there's been a significant expansion also of research, specifically looking at ethnocultural differences in terms of in vivo biomarkers of Alzheimer's disease. For those who are less familiar, we've gotten to the point with Alzheimer's disease research where we actually have developed in vivo fluid as well as imaging biomarkers where we can detect Alzheimer's disease pathology in the brains of those who are still living. These biomarkers are critical development in that they will be a major component of Alzheimer's disease therapies. So we will ultimately enter into a world where individuals will go to a clinic, will receive biomarker testing that could be as simplified as a blood test, and this would actually be part of their screening for potential Alzheimer's disease therapies. The chart on the right is borrowed from an article by Maeda et al., demonstrating that over the course of 2000 to 2013, looking at the incidence rates per 1,000 person years, you can see that there are significant inequities in terms of the ethnocultural groups represented, where as individuals age being the greatest risk factor for Alzheimer's dementia, you can see African-American individuals having higher incidence of Alzheimer's disease dementia compared to other groups. Why is it important to have representation of diverse ethnocultural groups in ADRD, Alzheimer's disease and related dementias research? Well, we think about the socio-ecological model of health in particular, where we understand that health is the byproduct of not only genetic and biological factors, but it's also, there are contributions, also from medical care, individualized behaviors, the conditions in which we work and live, as well as social and economic opportunities. And there are larger influences from factors like racism, structural racism. So what we understand and know is that where you were educated, how much money you have in terms of midlife income, early life childhood, socioeconomic status, pollutants you're exposed to, and your own individualized health behaviors these, along with your genetics, these all influence ultimately your pathology, and these influence as well your fluid biomarkers of disease. And so if we don't have representation of diverse ethnocultural groups and representation of diverse individuals in general, we don't actually get at this socio-ecological model of health. And so we begin to form a strong knowledge base with regards to fluid biomarkers of Alzheimer's disease and other conditions that's very limited in scope because it's drawn from a very limited population. And so for my project, I look specifically at data in what is called the Alzheimer's Disease Neuroimaging Initiative, also known as ADNI. ADNI is one of the longest running longitudinal studies of Alzheimer's disease in the world. It has biomarker data, imaging data, fluid data, which is typically blood, plasma, as well as cerebrospinal fluid. It has this biomarker data for hundreds of individuals from across the United States. ADNI has been run in different iterations. So there has been an ADNI 1, an ADNI 2, an ADNI 3, and an ADNI Grand Opportunity. These are all just different iterations of ADNI over the course of time. And with this database, it's publicly available, but it allows us to answer some of these questions around biomarkers in Alzheimer's disease and related dementias. So what I was interested in investigating was whether or not African American and Latinx individuals had significantly lower cerebrospinal fluid and plasma levels of some of these biomarker concentrations of Alzheimer's disease. This hypothesis was based on previous research and previous literature that has been done, which has suggested that African American and Latinx individuals may potentially have lower levels, lower concentrations of these biomarkers despite the increased prevalence of dementia. And so I took data from ADNI, from the different iterations of ADNI. I focused really in terms of the primary selection criteria on availability of plasma biomarker data, as well as the self-identification in terms of ethnocultural status. Why plasma data? It has a lot really to do with access. So when we think about how are these tests ultimately going to be used and how are they going to be made accessible, a plasma-based test, which is essentially just a blood test that you can get drawn in pretty much any clinical office, is going to be much more accessible compared to something like a lumbar puncture for cerebrospinal fluid, or something like a specialized PET scan for an amyloid PET. And so plasma biomarkers really hold promise in terms of their access, which we have to think about when we think about equity. So in addition to these primary selection criteria, the way I went about performing this study was that I used a 1-to-3 matching strategy where I matched the group of African American individuals to a unique group of non-Latinx white individuals, 1-to-3. And then I also separately matched the group of Latinx individuals to a unique group of non-Latinx white individuals. Again, 1-to-3 matching. I matched according to age, sex, education, mini mental status, which is a bedside cognitive screen. CDR-SB stands for clinical dementia rating sum of boxes. It's essentially a functional scale, so how impaired somebody is based on their cognitive symptoms. And then family history of dementia. I did an unadjusted as well as an adjusted comparison between the groups. And this was a cross-sectional analysis looking really at these plasma and cerebrospinal fluid biomarkers for Alzheimer's disease. So in terms of the results, this data has been published in Alzheimer's and Dementia. Just a little bit about the demographics of the participants. So we had 47 African-American individuals. They were matched to 141 unique non-Latinx white individuals, 43 Latinx individuals. They were matched to 129 unique non-Latinx white individuals. There was overrepresentation of individuals identified as female. This is pretty common in the literature. If you look at a lot of the biomarker literature, specifically looking at ethnocultural comparisons, there's overrepresentation of African-American and Latinx women. Most of the individuals were relatively highly educated. This is also something that very commonly comes up in the biomarker literature, where even though we're looking at diversity in terms of ethnocultural status, we may not necessarily be capturing the most diversity in terms of educational status. One of the things that's really important to know, as I mentioned, we did both an unadjusted comparison and then an adjusted comparison afterwards, where we factored in obviously past medical history, cardiovascular status, et cetera, you can see the really high prevalence of cardiovascular disease among African American and Latinx individuals. So these individuals were matched 1 to 3. We didn't specifically match in this case for cardiovascular disease, but you see the significant differences between cardiovascular disease rates. This is one of the hypotheses behind why African American and Latinx individuals may actually have lower biomarkers of Alzheimer's disease, even despite greater rates of dementia. It's because those greater rates of dementia are hypothetically being driven by things like cerebrovascular disease. And so in terms of the results, just a little bit of orientation. The next couple of slides are going to look very familiar to this one. What we're looking at is a comparison between two ethnocultural groups. So in this slide, it's African American to non-Latinx white individuals. We're looking at two different biomarkers as well. So we're looking in this case at plasma phosphorylated tau, which is one of the biomarkers for Alzheimer's disease. We're also looking at a different biomarker called plasma NFL, or neurofilament light, which is another biomarker we frequently use in the setting of Alzheimer's disease and dementia. The colors represented down below are colors representing the level of impairment of individuals. So the gray representing cognitively normal, where each dot represents essentially a single individual. The mid blue representing individuals with mild cognitive impairment, and then finally the dark blue representing individuals who have dementia level impairment. We looked at the positive false discovery rate for these because there were multiple comparisons in the unadjusted test. And so what we found in looking at this is that for the plasma biomarkers of Alzheimer's disease, we did not find significant differences in the unadjusted comparisons when looking at African American and non-Latinx white individuals. After adjustment, we also did not find significant differences in these plasma biomarker concentrations between these two ethnocultural groups. What about cerebral spinal fluid? I mentioned this is a little bit more of an invasive test. It actually requires a lumbar puncture. So here we were looking at cerebral spinal fluid levels of what's called amyloid beta 42, which is one of the markers of Alzheimer's disease we frequently use. We were also looking at cerebral spinal fluid levels of what is called total tau, and also what is called phosphorylated tau. Again, all of these in the setting of looking for Alzheimer's disease specifically. We again didn't find any significant differences when we looked between the two ethnocultural groups in terms of fluid biomarker concentrations for these three distinct entities. How about for the comparisons between Latinx and non-Latinx white individuals? So again, going back to the plasma biomarkers. So here we're looking at plasma phosphorylated tau, which we've talked about, and plasma neurofilament light, which we've also mentioned. And we're comparing, again, Latinx individuals compared to non-Latinx white individuals across the different levels of impairment. So looking at the plasma biomarker concentrations, we did not find significant differences between ethnocultural groups in a comparison in unadjusted or adjusted. Interestingly, when we look at cerebral spinal fluid biomarkers, again, looking at cerebral spinal fluid amyloid beta 42, cerebral spinal fluid total tau, and cerebral spinal fluid phosphorylated tau, what we actually found is that we found a trend towards lower cerebral spinal fluid concentrations of total tau and phosphorylated tau among our Latinx individuals compared to our non-Latinx white individuals in the unadjusted comparison. You can see the PFDR, positive false discovery rate, doesn't quite reach 0.05, but there's a trend in this direction. However, after adjusting for covariates, I talked about some of the covariates, including medical history, cardiovascular risk status, things like that. There was no longer a significant difference between these ethnocultural groups. And so overall, what did we find? We found that race and ethnicity did not contribute significantly to differences in cerebral spinal fluid and plasma biomarkers of Alzheimer's disease and related dementia. I mentioned we found a trend towards lower CSF biomarkers and some of the markers among Latinx compared to non-Latinx white individuals, but these differences were no longer significant after adjustment. We did have a relatively small sample size. We had limited information with regards to other sociodemographic variables and social determinants of health as well. I think one of the take homes from this is really critical to realize is that race is a social construct. It's not biological. And this is unfortunately really how it's frequently been treated, particularly in the biomarker research, where somebody's ethnocultural status, means race, ethnicity, has been assigned essentially as a biological variable without inclusion of sociodemographic variables, social determinants of health. And so there are these broad generalizations that are made about race and ethnicity with regards to disease pathology and biomarker status, but oftentimes they're ill-informed. Obviously, there's a tremendous need for additional larger studies in this pursuit of equity and this pursuit of understanding ethnocultural differences in these biomarkers. Tremendous thanks again for your attention this afternoon. Tremendous thanks to my primary mentor, Dr. Gail Rabinovich, as well as the ADME collaborators and coordinators and the patients who have contributed data for this project.
Thank you so much, Dr. Windon, and thank you all to all our emerging scholars and to our keynote speaker. Now we will turn it over to Dr. Bibbins-Domingo for some initial impressions on these talks, and we are putting her on the spot with this.
Thank you so much. I really enjoyed these areas. I think one of the wonderful things about investing in scholars early in their careers is that they approach each of the distinct areas they're working in through their own lens, and I think and through a lens that helps us to understand not only in these cases many of these areas that they work better, but also through an equity lens that helps us to understand these conditions in a way that that really points to distinct features, unique features we have to consider in the populations that might be disproportionately affected or at risk for worse outcomes. I like that for each of the talks, they've really pointed to areas where this work builds towards and leaning towards not just descriptions of things that might be different across populations, but to inform interventions to really address and improve health outcomes. And so I think they each in their own way speak to the next set of experiments, the next set of investigations and discoveries that are sort of necessary to get us to that point. And I think it was nice across a diverse set of studies to really see in each case those areas really highlighted. And so I think congratulations to the scholars, and really looking forward for each of you to what comes next.
Thank you so much, Dr. Bibbins-Domingo. Now we are happy to take questions, and I know that there are a few in the Q&A, but please feel free to keep adding more, and we can start with the first one. So I think this first one, Dr. Bibbins-Domingo, is for you. It's Dr. Shrestha. It says, thank you for inspiring presentation. How did you determine the occupation of the older adults who were retired, or did you exclude them from your study?
Great question. So for every death certificate, presumably the information is from a family member, maybe a physician who was taking care of the patient, and for another collateral source. So in the case, we did not, for the entire study, we did not, in all of our work, we've not excluded older adults. And in the occupation work, we basically looked at an age of adults up through 65, so that it was more likely that these occupations would reflect active occupations at the time or around the time that this person might have died. we can't exclude that, for example, and we know that older people might be working and that younger people with that occupation, it might not have been an active occupation. So the only restriction we placed on that specific analysis was to limit it to adult ages up through age 65 to increase the likelihood that that occupation reflected something that was active at the time that the death occurred.
Thank you. There's one more question in the Q&A, but I'm going to jump the queue a bit and ask a question for our emerging scholars, and perhaps if the emerging scholars could turn on their videos and join us. But kind of going off of the presentation by Dr. Bibbins-Domingo, I was wondering if you could speak a little bit to how you've involved stakeholders in your research, or how you hope to involve stakeholder in your research, and who individuals change agents may be for your individual research topics. So just thinking about the wonderful presentation that we heard earlier today. And any of the panelists, feel free to jump in.
I can offer some thoughts. So I think in terms of involvement of stakeholders, so when I think about inequities in Alzheimer's disease and related dementia, I really think of kind of a multi-part process. So I focused on just a very narrow window, but inequities in my mind start all the way back in really the community. So for example, if I don't know about Alzheimer's, I don't know about normal aging, I don't know about dementia, I'm never going to actually get to the doctor to talk about what I'm potentially experiencing. And so there needs to be education that's had. We've done, and I work as part of a tremendous outreach team, we've done a lot of work in this area where we've partnered with community stakeholders to help educate people in the community about Alzheimer's and dementia. But it goes beyond that. So even if we're educating individuals in the community and they're making it to their primary care office, who's to say their primary care doctor actually knows what to do with cognitive complaints? So there's the issue of primary care education and equipping primary care doctors with actual tools they can use to efficiently and accurately kind of evaluate folks. So I've worked with primary care doctors and partner with some primary care doctors at health clinics within the San Francisco Health Network to try to accomplish this. There are also large initiatives like Dementia Care Aware that's really seeking this marriage between more specialized providers and primary care physicians as a means of improving dementia care ultimately. And so I think about, that's just one part of the inequities pipeline. Then there's the whole part of getting to the doctor who's more specialized, et cetera. But every step along the way, in my mind, there is the opportunity for partnership with stakeholders. And those stakeholders truly end up being an asset in terms of trying to, I feel like, increase the scope and scale of equity work.
I can also speak to that a little bit. My work is a little less applied in the medical sphere, but one thing I've been learning about at CADC is how to do community-based participatory research. And that's something that I would like to do in future studies, where I actually am asking the participants, like, what areas of stress or adversity are we not talking about? Our assessments covering what is important to you. And I also would like to do that with kids in puberty, because I feel sometimes we make assumptions about what would help. And I think there's room for being more of the receptive listening, I would say. So that's one way to think about it for me.
I can also provide an example from my own research that I think the more I'm doing the intervention research, the more I recognize how important it is to have the stakeholder involvement into the research. So research is not only like sitting on the publication or research only, but really come to the real world solution to solve the problem. And like, for example, in my interventions research right now, I always reminding myself that I'm not develop intervention for young adults, but I develop intervention with young adults. It's really changed the way I work, the way I do the research, because I hear what they need. I want to develop something that meets their needs, other than what I think that is correct, that is based on theory. So that's something I think is very helpful and keep guiding me throughout the day-to-day working to develop the intervention to meet the individual needs.
Thank you all for those answers. And yes, I think even as an early investigator myself too, I think it's nice to kind of think how we can think broader and how we can have a greater impact with our work.
So I'll take on the next question that is in the queue. And I think this was directed to Dr. Bibbins-Domingo by Dr. Schwartz. The question is, any suggestions for how to be proactive for minimizing harms from stones that might be thrown in unintended directions when working on controversial topics? And I would also want to add, if Dr. Bibbins-Domingo have any guidance or advice for our 3 awardees today in their areas of work, or what might be potential stones or unintended directions for their work.
Yeah, so I have to say, we oftentimes think of controversial areas of research. It's easy to think if you are the things that are in the news. We're in a very highly polarized environment right now where things are where the actual conduct of science itself is being challenged. There are so many political issues and threats to the practice of medicine that have taken on these larger political overtones. So one thing I would say to all of to those of you, so it's easy to say, well, those are the hardest ones, because in some ways those are the hardest ones. If I were speaking to the scholars who were talking today, I would also just think through the ones that can sometimes be stones in a much more micro way. So that might be you ultimately have there are ways in which financial incentives in healthcare ultimately set up a reason why we practice in one way and not another way. There are other types of ways in which we're a very complex, multi-sectored environment that ultimately leads to the types of health outcomes that we see. And, several of you alluded to the fact that when we see these very disparate health outcomes, the reason we got there have to do with multiple factors. Each of those, we call them structural determinants of health because it's not by accident that they sort of got there. They've developed over time because of historical biases, because of entrenched interests, because of a lot of other things. And so what I love about folks who are early in their career is that you have to take things on, just believing that understanding these things better can change them. But I think you'll quickly encounter that there are reasons why we've not studied things before, we've not changed things before. It's not always a gap in knowledge that's gotten us there. It's oftentimes something else. And so what I'd urge you to do is to keep doing what you're doing, but to recognize that no matter what field you're working in, you'll oftentimes encounter whether it's just we've always done things this way, this is the way scientifically we always think about things, this is the way, or there are larger sort of entrenched interests that is the reason we think about things in that way. And in doing that, you just have to recognize there's a reason that those are inevitable. And then to think through how, with mentors, with other collaborators, that you work around those areas to continue to move forward on the things that are most important for you. I would say sort of in the broader area, oftentimes people early in their careers ask these questions, and I want to acknowledge that one feels less able to take risks earlier on in their careers. It's a lot easier to think about doing those later. On the other hand, when you're later in your career, you're probably not, you may not actually be as open to thinking in new ways about things. I think this is where, for me personally, I have benefited from really good mentors who've helped me to understand what ways in which to say things, what types of things to take on at what times, and to do that in a way that both preserves my ability to use my platform at a university to speak from that, which does give me a platform to speak, but to do that in a way that I'm not losing my job, frankly, but still trying to move certain areas forward. I would say one thing that's important is, well, I think this is teamwork. It's partnered work. It's your partners that are going to help you to understand where there are areas of trouble and where there's not. You have to understand how to keep yourself whole in these types of environments, because that's probably the most important thing, is to have people who stay in the game, always doing the type of work that we're all talking about, and then to be creative, to figure out how to do this. This is an environment, we're in an environment where the threats, I think, to the conduct of science and the ethical practice of medicine are probably in some ways greater than they've ever been, because there's a lot of big political forces behind them. And I think it does require us, more of us, being able to use our voice to speak, and to do that with some authority, and that requires us working as a team to figure out how each of us can do this at the career stage that we're in.
Thank you, Dr. Bibbins-Domingo. That's really helpful advice around the structural barriers and a lot of guidance about how mentorship is really important, helping us navigate this. I wanted to pivot a little bit about your role as now an editor of a major medical journal, and provide some guidance to our awardees today about how are the best ways to communicate their science, their findings, maybe in traditional journals as versus, less traditional or more innovative ways that we're doing now.
Yeah, it's a super great question. Thanks for asking. Here again, I would really urge you to use your mentors that are out there. I will say that publishing in journals can sometimes be can seem daunting. It's journal editing and the whole process of submitting and publishing in journals can be a very opaque process. I have to say it was for me for most of my career. I've never spent time on the other side thinking about this as an editor. The advantage you have of working with mentors is they're usually become very experienced in the journals that are important journals in your field and things like that. The advice that I oftentimes give people early in their career when they say, well, how would I decide which journal I'm going to publish in? How should I make those decisions? I really think about journals as like, who do I want to read this work? I really do think a lot about like the end result of this even a small piece of science to like, who do I want to read this? Is it a policymaker? Is it a clinician? Is it another scientist who can do the next experiment? That can oftentimes help you to understand like, which journal am I writing for? Because those are the readers of those journals. Recognize that journals have styles in which they write, and understanding those styles ends up becoming important, I think, for framing the work that you're doing in the style of that journal, which is usually in the style of the readers that they think the readers are receptive to in that journal. It always feels like an adversarial process, submitting to journals. For the most part, I don't think it has to be. Obviously, there's like, you're not going to get everything in. There's going to be rejections. There's going to be reviewers who don't like it. But I think the best journals are about trying to help decide that how to bring the science forward in a way that's best for the readers of that science. That's what I really believe. It might not always feel that way. And I think authors can do the best by really understanding who their audience is and how they choose a journal to actually and work with journal editors to actually bring the science forward in a way that is both true to the science and understands the context, which is what you do in a discussion. Another piece of advice I would say is I think the discussion is one of those wonderful opportunities that those who are more experienced in this field and who understand the power of a discussion section is one that I wish everyone would use to the fullest extent possible, to really tell us what you think that finding means, how it drives the next set of science that should be done, and what are the implications for it. It's such a powerful and underused tool, and don't use your discussion sections just to tell me the limitation, restate the results and the limitations of the work, because the opportunity is to tell us what the context is. I will say that helps editors and it helps journals, to think about why this work is important. And then I would say, none of us on the academic side are perfect. None of us in journals are perfect. One of my mentors early on helped me to understand what it means to be strategic in choosing a journal, what it means to push back on a reviewer who's not right, what it means to appeal a journal decision when the journal got it wrong. And I think over time with your mentors figuring out how to do that, it doesn't work all the time. It works rarely, I would say, but I think they're important skills to learn. And I think it's important to be active sort of in this process, because we're all authors, but we're also all readers of journals. And so understanding all aspects of that is important. I will say I am a big fan of these less traditional route. Like I have become a fan and recognize the role of preprint servers. You have to understand the pluses and you have to understand the minuses. I'm a big fan of other types of communication. So any chance you have to learn how to talk about your work to a broader audience, like in a media interview, in a public session like this one, to communicate to a broader audience. I think learning how to communicate about your science outside of the pages of a journal is a really wonderful skill to develop. And I never missed an opportunity to do more communication training, because I think those can be really helpful, both to make you better communicators to other scientists and clinicians, as well as to a general public. So that's just some quick thoughts, but I'm happy to entertain any other questions also.
Thank you so much. I guess I want to invite the scholars, and processing some of the advice that Dr. Bibbins-Domingo just shared, how they would want to summarize or share the science they presented today in a couple of sentences about what they learned and what are the challenges or work ahead. And so I will, if anyone wants to jump in.
Don't be shy.
I can be first. I want to reflect. Even I'm one of the speakers of this panel, but I'm learning a lot from every speaker today, that I see the really diverse the research area. We are trying to contribute, even we have the same goal that we want to advance health equity. But the way we are doing the different type of research, our method, really, I think it's very interesting, and I'm really appreciate that MERC create this symposium. So that's, as an early career researcher, we can learn from each other, and also have this senior pupil like Dr. Bibbins-Domingo give all of the advice that I take note about that. And my takeaway from this one, I will practice my communication skill, because the framework when she showed from the Lancet journal still stick in my mind right now, and try to understand each the contract and step from this loop, how to from the strategic question to the end of communication and backward, and then like going to flow like that, how I can integrate it in my work. Really, I think it's not easy, but that's the way I will, very helpful for me to more intentional about what I'm doing. Thank you so much.
In kind of line with that, I particularly appreciate Dr. Bibbins-Domingo, the data you presented on SALT in particular. And I've heard you talk about it before, but I think it's very useful for me, because it really makes me think about what you mentioned with regards to stone throwing as well as stone building. And I think oftentimes as researchers and as scientists, we don't realize the level of influence that we can potentially have. We oftentimes actually don't even exercise avenues by which we can increase our influence, where we can increase our spheres of influence. And so I think taking a step back from, obviously the data mining and the statistics and then the scientific writing, but taking a step back and looking at the larger picture of what is the goal of this, and what can I do with this data? What can I do with this project to really actually make a difference, to really start to, grease the wheels of change, so to speak. I think that's something that I very much appreciate from today's session. So thank you for that.
Yeah, I also, the image of the stone makers and the stone throwers also resonated with me, because sometimes especially as a clinical psychologist who's thinking about intervention, when you're talking about these early life factors that have this really negative lifelong effect, it's kind of like, well, what do you do with this? If they've already had the trauma, there's already, I can't change the past. But if I think about it in terms of maybe it can be used to advocate for how important the early life is, and we need more support for children, especially children in poverty, and also puberty, and how important puberty is as a period of risk and opportunity. So I think ultimately, I never thought of myself as a policy person, but I think kind of similar to what was done with the COVID project is that your research can be used to support a larger plan. And I've been recently thinking about my take on mental health. I have another line of research in depression, specifically depression during puberty, and how my focus has always been on fixing individuals, but sometimes it's like we need to fix the big picture.
Mm-hmm.
Like, I mean, it's like it's kind of asking these individuals to fix themselves, and there's just no way it's going to be done like that on a one-to-one basis. So I've been trying to think more from a public health perspective, which is not, what I have traditionally been trained in. So, yeah, but I think
I love each of your reflections. It's so wonderful to hear each of you talking in that way. I mean, I would just say back that careers are long. You're not going to do this all at once. Everything requires teamwork. And so there are multiple pieces, but I think each of you reflecting in your own way about how you do this, like do something else from the work that you're doing in the context of, your own line. That's actually what it takes, because you'd be surprised how you thinking a little more in that way really helps to open up a field in ways that people who are on the other side are like, oh, I never thought I could use this type of evidence for something else. And you don't have to do it all yourself. Like you have to just like think enough about it that you can get it to the next person to do that piece. So it's really great. And I think it also turns out makes your careers much more interesting and satisfying. So.
I think it's time for me to bring it. I froze. I think it's time for me to bring us home. So I really, wow, what a great symposium. Just got better and better and better with every minute. And I'm so grateful to Dr. Bibbins-Domingo, but also to Dr. Nguyen, Dr. Hamlat, Dr. Windon, to Dr. Garcia and Dr. G, and all the folks that introduced our speakers today. Really, it does take teamwork. It takes a community. That's what we're working on building with MERC, is building a community of people at UCSF, researchers at UCSF that have equity at the center of what they're doing, that are paying attention to which questions we're asking, so that we're asking impactful questions, and that want to be doing this work together, and to at least encourage each other, even in different lines of research, encourage each other as we move forward, because it does make your career and your work much more meaningful, rewarding, and fun. So I've had a lot of fun here today. I hope all of our attendees have as well. And please, if you haven't already had a chance to fill out our final feedback survey, that would be really fantastic. And I think that and I think we'll probably be able to send that to you as well, or to all the attendees after the meeting. So take care and enjoy the rest of your afternoon and your weekend. Be well. Thank you, everyone.